Αγαπητοί φίλοι, καλησπέρα και καλή σχολική χρονιά. Εύχομαι να περάσατε όλοι ωραία το καλοκαίρι. Και ναι, φωνές ακούγονται. Και μπαίνουμε στα σεμινάρια δυναμικά με ένα πολύ προχωρημένο θέμα. Management of severely maxillary and manibular atrophy by means of subperiosteal implants. Διαχείριση σοβαρών απορροφημένων, τέλος πάντων, περιστατικών άνω κάτω γνάθων, μεγάλες ατροφίες με υποπεριοστικά επιτέματα που έχουν μεγάλη ιστορία. Μαζί μας έχουμε τον Μάουρο Cerea. Αν το είπα καλά το όνομα, καμιά φορά κάνουμε και βλακίες. Οπότε σταματάω να μιλάω ελληνικά, λέω ένα καλησπέρα στον Μάουρο και συνεχίζουμε. Mauro, thank you very much. The microphone is all yours. I just said some bad things about you in Greek that you don't understand. Just kidding.
Okay, can I start? Welcome everybody to this evening. I want to talk to you about superiosteal implants. I want to introduce myself. I am a medical doctor, maxillofacial surgeon and dentist. I was born in Italy. I work in Italy, in Bergamo and Milan. And I want to show you the new superiosteal treatment, fully digital, custom-made, in cooperation with our Greek cooperation with Cardiodental is our partner in Greek. And Eaglegrid start where the regenerative technique end. This is some negative items about regenerative technique. Unpredictability of the quality, quantity of newly formed bone. Outcome depends mainly on the surgeon's skill. Long time for restoration and no immediate load. It can be recidivated by memory effect or bad patient habit. If you think about sinus leaf in heavy smoker, for example. Highly biological cost, especially if the graft is autologous, not from the hip, but from the calvaria, from the head. In the literature, we have two deaths of patients, one in Italy and one in France, for the complications of this aggressive surgery. And currently, non-commercial methods, because today our patients want an immediate load, only one surgery, a long follow-up of the treatment, aesthetic and comfortable prosthesis, surgical intervention targeted to clinical needs, high treatment predictability, and low biological cost. So, Eaglegrid no implant system. Eaglegrid is a company who started 11 years ago. We have the best quality product of implant subperiosteal in Italy. We have patented 3 surgical protocol of our digital follow-up. Eaglegrid because the grids, if is compared at an eagle, similar at an eagle with the wings and the feet. When the project was born 11 years ago, we have revisited the superiosteal implantology in a digital workflow, adapting the new product to the needs of the dental and the patients. In all cases where it is not possible to perform an endosseo implantology or where a regenerative technique is not recommended. It covers all the needs of the dentist and the patients at 360 degrees, being able to guarantee rehabilitation of a single tooth loss or a saddle or a fully arched mandible or maxillary. Eaglegrid is a superiosteal digital implant. And in this evening, we start to talk about physiopathology of the bone resorption, the severe atrophy. The resorption after extraction depends mainly to the loads. If the load is directly into the bone, the resorption become lesser, become nil in the literature. In the severe atrophy, we have to divide the maxillar bone resorption, who is centripetal, and the mandible resorption, which is centrifugal. In the maxillar, the vertical resorption is due to the remodeling of the alveolar crest when the teeth are loose, and pneumatization after this sinus maxillary expansion. But from a transverse perspective, the bone resorption is centripetal, is very important for the prosthesis, for design of our prosthesis. And the area surface of the arrows are similar at the aggressivity of the resorption is mainly higher in the frontal sides of maxillary than in the distal portion. Sometimes our prostheses or teeth of prostheses are in front of the alveolar crest for this reason. It's very important for the design of the grids and for design of the inclination of the abutment. In the mandible, the resorption is centripetal in the anterior side, is centrifugal in the posterior. But what's the difference about mandibular and maxillary resorption? The maxillary can to resorb completely, also in the basal bone. But in the mandible, when you speak about endosseal implants, we have to calculate the percent of the bone residual above the channel of the nerve. But in the subperiosteal implant, we can use also the bone under the channel of the nerve, all the bone of the mandible out and in. The biomechanics of mastication is very important in our protocol for the design of the grid or the frame of these grids. The masticatory pressure on the maxilla is physiologically exerted from one structure to another in succession. We start from the teeth, alveolar bone, splanchno-cranium, and neurocranium. When you lose the alveolar bone, the prothesically teeth, you can obtain the alveolar bone with the regenerative or directly rest the loads directly in the splanchno-cranium. But at the splanchno-cranial level, we have to identify the buttress of fascial resistance. It's very important. Also in maxillofacial fractures. In the splanchno-cranium, we have some buttress made from density D1 of Lecolmed-Zarb classification. And these buttresses are a form of a pyramid, a tetraedric pyramid, are very strength, very stiff, and are not resorbable by the loads. Classically, we have the canine or nasal buttress, the zygomatic buttress, and the pterygoid buttress. So, the canine buttress you can use in endosseal implant and or the prosthesis. The zygomatic buttress is utilized in implant, but it's not prothesically guided. It's very difficult to join for the inclination the zygomatic implant to the prosthesis. And the pterygoid buttress in the pterygoid implant is used like a canine buttress. If you join these three buttresses, you obtain a triangle. You obtain a triangle shape, which is a not deformable shape, geometrical shape. This is a triangulation of loads. It's very important in our protocol to obtain a triangulation of loads of our Eaglegrid for the loads of the teeth, for obtain a long follow-up. The palate arch is another buttress transverse in horizontal portion that join the left and the right side on the loads of the splanchno-cranium. Also, if the bone of the palate is very thin, 1-2 millimeters, upper we have three ribs, vertical ribs, with guarantee the passage of the loads directly in neurocranium. We have the septum of the nose and the vomer bone. We have the medial portion of the sinus and the foot of the zygoma in the sternum. So in this animation, we can do the simulation of the loads, physiological loads from the teeth to the buttress to the neurocranium. Our Eaglegrids follow the buttress, this buttress, to obtain the similar physiological passage of loads in this buttress to the neurocranium to obtain this object. In the mandible, we haven't buttress, but we have a preferential direction of loads by the teeth to the bone, and these loads pass to the vestibular cortical portion of the mandible. And you can see in this picture as the portion of vestibular is higher than the lingual portion, is thin. And when you lose the teeth, the lingual portion join to the vestibular portion. The centrifugal resorption of the mandible is due to this effect. And also in the severe atrophy, you can have in the vestibular portion of the cortical mandible from 4 to 6 millimeter of cortical bone for our screws to obtain the load of screws in the passing of this directory of the loads. The supperiosteal implantology in the past was a very widespread technique, but it was abandoned because there were a lot of failure in a short and long time with high bone resorption. We start from here. We start from Eaglegrid to obtain the reasons of the bone resorption. The bone resorption in the past was due a wrong ratio load surface, rest on a bone with a low density, micromovement during the function for misfitting, and allergy to metal. In this picture, you can see an old supperiosteal implant with all the causes of bone resorption. We have a wrong ratio of surface and load. We have the bone, the implant who rests on the bone or low quality, alveolar crest, residual alveolar crest, misfitting due to the analogical production in the past, and not a fixed screw for the movement, micro movement, and made in stainless steel and not in titanium. So we start with the new supperiosteal protocol now with a high density CBCT. We do perform only one intervention. we made in selective laser melting or structure rest on resistance buttress in the bone type D1, fixed with titanium screws, and the bridge is joined sometime with implants if present. We have a primary stability for intimate contact with the bone and exploitation of possible undercuts. We have a secondary stability due to screws, and third stability due to fixation of the prosthesis with implants if present. Operative protocol. This picture is very important for us because in our protocol we have two big advantages of Eaglegrid implants: anatomically guided and prosthetically guided. It's very important for the quality of our products and for the long follow-up of our products. We start performing a CBCT, executing with a high definition with the section of 0.2 millimeter or less, using a large FOV and wearing a special radiological template. What's a radiological template? A radiological template allows to the software to relate the maxilla or mandibular to the antagonist in order to perform a prosthetically guided design. In this picture, you can see the model, master model, the WhatsApp. The WhatsApp is the radiological template. WhatsApp, or you can use also the prosthesis, the temporary prosthesis, removable prosthesis of the patients if you want, without metal, in this case, with little drops of flow composite to marker, or you can use also a little ball of quartz for marker. In this case, we used a brick of a radiological template, and we do a duplicate of the prosthesis of the patient in radionegative resins. The patient in occlusion perform a CBCT like this, and this is the result. In full digital, we have the anatomy of the patients, and we can start to design the Eaglegrid, join the buttress as you like I show you. But you start from the anatomy and you want to finish to the best prosthesis restoration that you want your patients wear at the end of the surgery or at the end of the treatment, the final treatment. We start from the final to obtain the Eaglegrid who is between the anatomy and the prosthesis. This is our secrets. And fine, running a 3D model using a segmentation software. So, design or a model directly in virtual CAD/CAM, indication of treatment grid with the prescription physician, is a design clinician, Delta clinician consultant to prosthetically guided design. I show you this old case because we published in international bibliography. We started to rehabilitation second portion of maxillary. In this case, we have in full digital all the information that we need. We have the design of the structure, the abutment, in this case for a cemented prosthesis. This is a 3D model, a virtual 3D model obtained directly by the DICOM of CBCT. It's very precise. Here we have our Eaglegrid design. We have the gingival, the temporary prosthesis, and the antagonist. We can use fully digital and we can work totally in virtual. Finally, it's sent to product by laser melting. What's a laser melting? Laser melting is a 3D printer that use titanium powder. In this little video, you can see in action the laser melting. Everything starts as an idea. Our idea is become a computer file, is translate in the machine language, STL, a layer of powder is spread out in 3D printer, titanium laser melting, their temperature is raised, a layer of the powder, a new model that is the shape. A new layer of powder is spread out, and the process is repeated many, many times to obtain a 3D shape. This is STL design. This is our Eaglegrid when exit from laser melting machine. Once polished, it is decontaminated in a white room, is packaged and sent to sterilization with saturated steam. This is a clinical case. We have to rehabilitation the second portion of the maxillary. Incisor, elevation of the flaps, or Eaglegrid is an old Eaglegrid with a polish treatment for a cemented prosthesis. A good fitting with the bone, fixed with a screw in particular position, stitches, suture stitches, and this is the healing of the gingiva or the periodontal tissue after 6 months. This is a temporary prosthesis, very ugly, I know. The impression, analogical impression, we haven't the scanner, intraoral scanner in this period. And this was the final restoration. We used a metal ceramic. Now we don't use semi-ceramic because it's too hard, it's too stiff, it's not remodeling by the occlusion. In this case, the patients disappear for 2 years for personal reason. And we think lose our implants because we can check the occlusion or complication or disocclusion of our prosthesis. But after 2 years, the patient appear to the check to the controls, and we remove the ceramic prosthesis and look our Eaglegrid in position with soft tissue, a good healing, a good work. We do a CBCT of control to check the healing of the bone of the Eaglegrid, and publishing this case as a case report in international work published. Each Eaglegrid will have an alphanumeric identification code for the traceability of the product process and the attribution for the patient for which is intended. In the grid's technique and manual include the design of the acquisition file, the prescription of a physician, design certification signed by a clinic for the design of the implant, design certification for the temporary prosthesis in PMMA from the technician, and the compliance certificate from the manufacturer. It's very important. This is our Eaglegrid made in Italy. This is a gold Eaglegrid. We speak later about the gold treatment of our product. A little video.
With Eaglegrid, advanced implantology reaches new heights with an excellent outcome, even in cases of bone atrophy. The high degree of surgical expertise of Eaglegrid staff is combined with the technological knowledge of the new Ancovis Dental Production Center, thus making a significant and innovative contribution to dental implantology.
So New Ancovis is our partner, is a company partner of Cardiodental Eaglegrid in Bologna. This is the CBCT, the segmentation of CBCT. You obtain a STL file put into the 3D printer to obtain a 3D model, resin 3D model, very precise. The clinician share the information with you and start to design the Eaglegrid with identification of the buttress and the hole of the screws. This design is converted in full digital, and the technician put the file in STL in laser melting machine, who works also in the night to obtain a precise 3D Eaglegrid. Is patented by New Ancovis the possibility to pass the Eaglegrid by the laser melting to the milling procedure to obtain the precision of the abutment. Check the precision of the machine. You can see our multi-unit abutment of Eaglegrid. And start the production of Eaglegrid prosthesis components. Transfer, analog for plaster, healing abutment, screws, scan body. There's a quality control to check the precision with the bone and to the other component. And then start a laser screen print identification for Eaglegrid for the traceability of the product and the attribution of the name of the patients. Then is sent in another company in Padova to packaging and cleaning in a white room. And device is a sterile packaging is used for surgical use. You can see the gold bioactive surface. We can speak later. Treatment developed with the University of Pisa. Some clinical case. We start with a micro Eaglegrid. Micro Eaglegrid is a Eaglegrid for only one loose teeth. In this patient, we have the agenesia of the lateral incisor. She had a treatment of regenerative technique with failure and position endosseo implant with failure. And the patient have lost also the residual bone of alveolar crest. You can see a bonding bridge. In this case, we start to product to micro Eaglegrids. Micro is only for one teeth loose. In this case, we use a cemented prosthesis. Quindi start to obtain the information with a CBCT, with this is the two Eaglegrid, and the screws avoid naturally the roots of the incisor and the canine teeth. Surgery, local anesthesia, positioning of the two Eaglegrids with screws, sutures, stitches, and first temporary prosthesis. The patients come out from the study with two temporary prostheses. We start a test drive to obtain the best smile for these young patients with a composite crown build-up. And we start to product another, the second temporary prosthesis to obtain the best quality and smile for patients. Final restoration with zirconia crown. Another clinical case is a young woman, is a Kelly syndrome with a severe atrophy of the maxillary, parodontopathic teeth in the anterior portion of the mandible, and severe atrophy in the rest and the portion of the mandible. We start with the maxillar. I show you these two depression of the bone are not due to extraction of teeth, but are transverse osteotomy is our surgical patented protocol to obtain best healing of gingiva. In this case, in this alveolar crest, we perform some osteotomy transverse, in transverse direction with a surgical template. So the Eaglegrid arch pass into the bone and not under the gingiva. So only the neck of the abutment can join with the bone, the residual bone, and obtain a good healing of the metal around the abutment, patented in Italy from Eaglegrid. This is the surgery of the patient. And you can see the patient wear directly temporary prosthesis. And in this situation, the patient was very happy for the maxillary, but not for the mandible. And so we start to product a study to perform the same in the mandible. We remove the teeth, the residual teeth, and we position 3 endosseal implants in the symphysis zone of the mandible, and design 2 Eaglegrid for the saddle, the distal saddle of the mandible. This is the surgery. You can see the screws to fix the mandible. You can see how many screws in the vestibular portion of the cortical bone as you have explicated before, is the best position for our screws in the vestibular portion of the mandible. 3 implants in the symphysis anterior position. This is the surgical X-ray control test of occlusion of color and aesthetic of the teeth. This is the patient at the start of treatment and the patient at the end of treatment, very happy. I want to show you this in an ExoCAD file. We want to share with you all the information before to start to product Eaglegrid. And so I send you via email this file. You can use all the instrument to remove, to change or check or work, but in the mandible you can also use this file to control the maximum length of the screws for not damage the nerve. If you see 4 millimeter and 6 millimeter screw in every hole, you can check the maximum length of the screw that you have to use in the wall to not damage the nerve. You can have a mapping of a surgery of the screws. And this is shared with you before the product of the Eaglegrid. If you agree with our product, with our design, we can start a second step of production. This is a little video of a similar case of a saddle in a mandible. You have to cut the keratinized residual gingiva in the middle, elevation of the flap, vestibular and lingual portion to obtain a good relax of the flap. Then you can use a surgical template for the transverse osteotomy. All this is included in the packaging of Eaglegrid, obviously. You position this template and using the burrs, round burr, to identify the position and the dip of the transverse osteotomy. You finishing the osteotomy with a precise burr and to check the dip of the osteotomy by the 3D model with irrigation of physiological solution. You finishing the transverse osteotomy, and you can check your surgery with a replica. It's the same of Eaglegrid, but we haven't the milling of the abutment, you can see, and we haven't the gold treatment of the surface. But this replica can to check the fit of the real Eaglegrid with the bone. This is the real Eaglegrid, the master Eaglegrid with bone treatment and milling of the abutment. We have already checked the fitting with the bone. We position the Eaglegrid on the bone and start to fix it with the screws. We have some burrs with stop to avoid to damage the nerve if you want in the surgical kit. Good position, good fitting with the bone. We start to drill the bone and use the screws in Eaglegrid kit. In this case, we have a product, a temporary prosthesis, but the clinician was to produce the prosthesis after the surgery, and so we use a scan body to obtain a 3D scan of the scan body for the prosthesis, temporary prosthesis. Stitches, scan body, Eaglegrid scan body. The long follow-up of these products is due to a clean surgery in incisor, elevation of the flap, and stitches are very important to obtain a long follow-up of the healing of the Eaglegrid. This case, courtesy of Corrado Palmas of Palmas Italia SRL, is our clients. Is a patient who arrive in our study in this condition. Is like a grandmother with a severe atrophy of maxillary and mandibular. This is the maxillary and mandibular. This is X-ray. You can see a severe atrophy of the maxillary and the mandibular. It's heavy overbite of this occlusion. I perform a surgery in general anesthesia. In a general anesthesia, we perform both maxillary Eaglegrid and mandibular Eaglegrid. This is the project of the mandible reconstruction. You can see the marker that we have used with the flow composite. And this is the two Eaglegrids in the saddle of the mandible. In the front, we will use endosseo implant. You can see the portion of the nerves between the two parts of Eaglegrid to obtain the maximum length of the screws. The maxillary is the same. We start with a template, a radiological template. You can see the marker of the prosthesis of the patients that use as a radiological template with flow composite. This is the position of our multi-unit abutment. The simulation in full digital the gingiva, the surgical template for the osteotomy, transversal osteotomy, and our Eaglegrid only one structure is a severe atrophy, horizontal and vertical atrophy, and we use both all the buttress, palatal buttress, canine buttress, and zygomatic buttress, joined by an eagle grid for the loads of the prosthesis, anatomically guided and prosthetically guided. This is the patients after the surgeon. I positioned also 2 pterygoid implant in the tuberosity of the maxilla. You can see at the end of the intervention the temporary prosthesis joined with T-base, and in the inferior portion we use 4 endosso implant and 2 eagle grid in a position. This is the healing of the soft tissue of the maxillary, and this is the first temporary prosthesis. After the surgery, the patient exit from the surgical room with a temporary prosthesis directly joined to the eagle grid abutment. You can see in this picture. When the healing of the soft tissue is terminated, we start to produce another secondary temporary prosthesis to obtain the best smile and occlusion and comfort for the patient. And in this case, we utilize also the loads on the eagle grids in the posterior seats of the mandible. This is a second temporary prosthesis to check the aesthetic and function of the patients. You can see the hole for the screws. From this prosthesis, we start to produce the final restoration. This is a simulation, a 3D check control of all the implants, subperiosteal and pterygoid and anterior in symphysis, before and after. Before and after. This is X-ray at the end of final restoration. You can see metal, titanium metal with a composite. And this is the aesthetic prosthesis, a maxillary and a mandibular. Titanium and composite. Before and after. After. Before and after. In this picture, in the left side seems a grandmother, in the right side seems a nephew. Eagle grid surgical kit. When you want to position eagle grid, we send you all that you need: screws, surgical kit, surgical template, 3D model, eagle grid replica, the real eagle grid master, and all the instruction. This is the surgical eagle grid. We have the hand screws and all the burrs to perform the transversal osteotomy and to drill to obtain the hole in the bone for the screws. And we have the rack screws in double packaging. You have to sterilize in vapor steam. You remove the cover and you have the screws of 2 millimeters and the emergency screws of 2.3 millimeters. This diameter and the shape of this type of screws are copy from maxilla fracture surgery for the fracture or orthodontic surgery who I performed in the past. You can have also two types of diameter and different length, 4, 6, and 8 millimeters. This rack is only for one patient. This rack is only for one intervention. At the end of the intervention, you close the cover, sterilize for the contamination this rack, and send back to us for refill a new type of screws, and you can pay the screws that you have used. Every rack have a code matching with the Eaglegrid identified number to obtain all the treatment used in this tract for the treatment of the patient. This is a multi-unit abutment of the Eaglegrid. Is B phases. We can use this multi-unit abutment, this MUA, for screws the prosthesis or cemented, screw the prosthesis or cemented prosthesis, because you have also a little hexagon for non-rotated abutment. And you can use a T-base for type of video, or in other cases, if you want, you can buy a cylinder for a cemented prosthesis, non-rotated prosthesis. This is the T-base of our Eaglegrid, and the screws are 1.8 diameter, and you can use the wrench up to 20 Newton centimeter of torque, wrench torque 25 centimeter per Newton of torque. You can see the neck of the abutment is polished, is clean, to obtain the best junction with keratinized gingiva. And the other of Eaglegrid metal is with a surface treatment gold that we have performed with the University of Pisa. This is a healing of gingiva in mandible, for example. You can see the perfect healing of the gingiva around the MUA, the multi-unit abutment, due to the transversal osteotomy patented by Eaglegrid. In this case, you can use the scan body and the intraoral scan to obtain the impression. This is the scan body of Eaglegrid. And you can directly have in your study the frame of the prosthesis. You check the height of the occlusion of the frame, you scan the frame, and the second passage, the second step, at the final restoration in composite and titanium, if you want. Biography. We published with the University of Pisa in Tuscany, two works about the contact of this treatment surface with osteoblastic cells and fibroblastic cells, gingival cells. We choose the treatment gold as the best type of results in this published article. Pterygoid implant in synergy with subperiosteal implant. Why? Because we want to use all the buttress of splanchnocrinium at the first of my presentation. And so with Eaglegrid, you can rest the load directly in canine, zygomatic, and palate buttress. But in subperiosteal, in pterygoid buttress, you can use a implant endosseous. You can see in this picture an Eaglegrid 6 abutment Eaglegrid and 2 pterygoid abutment in the posterior sides of the maxillary. In this case, you can see the synergy, the junction of one Eaglegrid implant with pterygoid implant. In this case, we use also a sphinx nasal implant in the middle to obtain a triangulation of the forces. And this is in my personal opinion, is the best results for the distribution of the loads in the maxillary. In this case, you can see the triangulations of the loads from zygomatic to palate to pterygoid, and the triangulation of the loads about zygomatic, palate, and canine or nasal buttress. Triangulation of loads is very important for the loads. In the total rehabilitation of the mandible in the symphysis must be considered for possible endosseo implants you have seen in the last clinical case, for example. If endosseo implants cannot be positioned in the symphysis, either 3 grids or 2 grids are hypothesized. This is very important. In this case, the shape of the symphysis can follow the direction of 2 grids or 3 grids for rehabilitation of the mandible. It's not possible to have one whole Eaglegrid in the mandible because the undercut of the mandible and the position of the nerve is not favorable follow-up for a whole full arch Eaglegrid. It's better to separate the loads in symphysis or posterior loads in the mandible. Or in this case, if you want, you can use 2 Eaglegrids from position of the canine to the molar, first molar, like in this case. We have thousands of Eaglegrid cases, and we have more than 10 years of follow-up, and we have the possibility to check the complication or all case in a retrospective works, because we have a lot of 100 and 1,000 cases of Eaglegrids in this case. We have a website for the patient or for the clinician. Is in Italy and in English for the moment. And Eaglegrid sell also formation, the academy. We have an academy to perform, to improve the skill of the clinician, of the surgery, during the course that we do in ICLO Verona. ICLO Verona is a building where there's a sectorial room. We sell from USA cadaver head, and they send us the CBCT of whole the head, so we can do product a 3D model and a metal eagle grid of the cadaver before that you can to use in ICLO. ICLO is in Verona, is near Milano. There's also an airport, Catullo, in Verona, or Milano, have Malpensa, Linate, and Bergamo, is very near. And is scheduled for January of next year with Cardiodental ICLO course. You can book now because the number is fixed in 6 attendance. You can book now in Cardiodental for January if you want. The course is scheduled in January. During duration is 2 days. This is the building in ICLO Verona. This is the sectorial room where we can do our exercitation on the cadaver. You can have a surgical kit, screw kit, surgical template. This is our patients. And for every patient, we have a 3D model and metal eagle grid. It's very similar to the real intervention. Thank you for your attention, and thank you for Cardiodental for this cooperation with us in Greek.
We thank you for the most impressive restoration. I'm speechless, to be honest. Everything seems to be extremely well thought of, and the execution is also wonderful. And if you have so many, hundreds of cases, more than 1,000 cases, it's very, 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 very impressive.
Oh, thank you. Thank you so much. It's a work of a life, of 10 years of my life. Igor Grid is my creator.
Yes, but you also helped change people's lives, because more of this, we don't realize it, but edentulous is handicap, is partial handicap. And you see how you transform lives of people that they have no other solution. And
Yeah.
with dentures, you can restore the aesthetics, but when it comes to function, you can only achieve 20-25%. So you're way back. And the psychological factor is really major. So you saw you showed as a patient that she seems that she was younger, 20, 25, 30 years at least. So you changed lives. And
yes, it's true. Yes, it's true. Our patients are very happy to obtain the function of the mastication and the aesthetic of the teeth loose, and very, very happy to use a fixed teeth to mastication again.
And also the fact that you showed how you prepare the area for the abutment, the osteotomy.
Yeah.
I think that was one of the major problems before. They were sticking out, on top of the ridge, but now you solve this your pattern, and it's lovely.
Yeah, we have reduced the complication of the exposure of metal of the grid of 95% with this patented surgical method. We have reduced so much the complication. We are very happy to improve this protocol. It's true that it is more difficult for the surgeon to obtain the skill to use the burrs on the bone, the surgical template, to use the replica for the fitting. But the final healing of the soft tissue and the long follow-up is very important for us. And so we perform some courses in ICLO Verona to improve the skill of the surgeon. I know that my colleague had very high capacity to manage endosseo implant, but superiosteal implant is a different type of implantology. You have another vision of the anatomy. And so I want to explicate this in 2 days. It is very important for us to obtain a better skill.
Really amazing.
Okay, thank you.
As expected, we don't have many questions from the participants because
I know.
it's quite advanced, We cannot put our a few cents of wisdom there because it's a very advanced subject. I don't know if Maria would like to make a comment, but I'm just speechless. I just have to say thank you. And I don't know, have you seen when people addressed Suleiman, in the old Ottoman Empire? Ancient, many decades ago, Suleiman the Great in Istanbul, Constantinople?
No, I don't know.
Okay.
No, I'm sorry.
You know where Istanbul is?
We start only in Italy to...
No, it's a joke. I wanted to say that I salute you, how they used to do in the Ottomans. In the Ottoman, the top of the Ottoman Empire, that people would bend on their knees and, salute as the king, that they would bend to the floor.
Okay, I don't know.
It's okay. Don't worry.
No, I'm sorry.
It's a silly joke.
Okay.
Okay, thank you very, very, very much.
Thank you to you, to Cardiodental, for this opportunity to show to you my work.
Sorry, Christos has a question. He says many clinicians are worried about infection rates of these subperiosteal implants.
No, it's
your experience on that issue. I think you said that you reduced, this kind of stuff with this thing 95%, but please.
The complication, I know that the attendants want to know the complication of this type of implantology. We have a total, we have to remove minus than 1% of all product grids for year. We have a rare complication that have to remove the grids. The complications are the infection in patient with diabetic or a heavy smoker, for example. In the early period of healing, you can have a super bacteria infection, and we have to remove some grids, especially in the mandible, but it is very rare because we want to perform to the patient's antibiotic therapy 1 or 2 days before the intervention, and the smoker have to avoid to smoke during the healing of the tissue, the soft tissue, and we have to check the patient for the day after the surgery very strictly to obtain the best healing of the soft tissue. The soft tissue are the seal, il sigillo seal around the MUA, the multi-unit button, and the position of the Eaglegrid is most critical. So we have to use care technique to incision, elevation of the flap, and application of suture or stitches without tension of the flaps, for example.
Silly question on my behalf. So you had the regular 2mm screws and the rescue ones 2.3. In your experience, how often do you need to go to the 2.3? Is it often, or you just have them just in case?
Allora, we use the 2.3 in the palate, for example, in the palate portion of the bone, and sometimes in patients who have bruxism, phenomena of serrational occlusion during the night. So we use Eaglegrid with the 2.3 in the mandible also. In other case, the 2.3 is an emergency screw when the bone is not so so hard to obtain a good torch branch with a 2.0 diameter of the screw. So you can use the 2.3. If the screws don't have a primary stability, you haven't to use the screw, because another complication of the Eaglegrid can to depends the fixture, the fixation about the screw. The screw are the little micro implants, endosso implants if you want, and like the endosso implant can to lose the osseointegration, and so can to we have to remove sometime, very sometimes not too simple, the screws during the healing. 2.3 in the palate, in my opinion, is a good position. Sometime in the mandible when the patients have bruxism parafunction during the night to improve the fixation of the Eaglegrid.
Thank you very much. It was very clear, crystal clear. Thank you very much again, and maybe I hope to see you soon. Maybe at you will never see me in one of your courses, because I refrain from extracting simple teeth, so I'm not
Okay.
don't like surgery, but it was really impressive. I'm sure the people who you give solutions where nobody else can help, so it's really impressive. And thank you very much.
Thank you. Thank
On
you to
behalf
you.
of the dental community. Take care.
Thank you
Bye-bye.
to you. Bye. Ciao, grazie.
Ciao, ciao.